Thanks for you all for the invitation to present during this session. So as John said, I used to be a PhD student at the VU, and I also did my training at the VU before that, so BSc, MSc, etc. And I'm now based in the UK, and here I focus a lot on a lot more than I used to on affective influences on balance control, so like things like anxiety and fear. And yeah, I'm going to talk about dizziness, but before I do that, I thought just give you, well, you already did that for me, John, but indeed, I wanted to give a little bit of background to myself. So my main sort of research focuses on applying psychological theory to movement control and learning, and to basically using that knowledge to not only understand better how certain things may go wrong in certain populations, but then also, of course, how you can then maybe improve certain movement control and learning deficits in these populations. So during my PhD, I focused on stroke, but drew heavily on sports science literature to inform my studies. But at Brunel, I focused more on Parkinson's disease patients and older adults with particular balance issues. So for instance, people with excessive fear of falling, but also, and that will be the main focus of this talk, people with unexplained dizziness. So if I have to visually summarize my research, it will look something like this. So focusing on anxiety, associated attentional processes, and how they may sort of coalesce to then influence behavior, sometimes adaptively, but sometimes also maladaptively. So why study anxiety? Well, as you might know, anxiety and balance control are really tightly linked, even at like a neurophysiological level already. There's evidence to show that there are strong links between those neural areas that are heavily involved in vestibular processing, for instance, and processing of other sensory information related to balance, and those involved in affective processing. And there could be reciprocal influences here that could lead to adaptive behavior, but also to deficits if something goes wrong. And it's therefore also not surprising that by itself, anxiety may actually be a risk factor for certain balance deficits in a variety of populations, even when there are no, for instance, physiological factors that could affect fall risk or balance control when these are absent. So what you can see before is, or what you have is populations where people have excessively cautious gait, so they move in a very cautious way, more so than you would expect them to do based on their physiological fall risk, and this actually by itself entails a fall risk. But also with older adults with unexplained dizziness, we often see that anxiety is highly comorbid. So basically most people who have unexplained dizziness without any clear vestibular substrate or other physiological substrate, they often have quite high levels of trait anxiety, and this has actually been thought to be a causal factor by itself, causing dizziness. So in this talk, I will explain how some attentional processes related to vigilance in particular may actually underpin this unexplained dizziness, according to us at least, and some early evidence for this. But I think some of these findings actually also apply, some of the mechanisms I will discuss also apply to people with excessively cautious gait. Okay, so first let's maybe take one small step back. So just to highlight how attentional influences and affective influences can control balance. So just really back to basic for just a short while before we get to the main meat of the talk. So of course, as you know, balance and gait were once thought to be almost completely even automatically controlled. And that has, of course, intuitively that makes sense, because if you think about your balance control and you would ask me, for instance, to describe how I maintain upright stance, I would really struggle to tell you about the details of like the mechanics of movement involved. I really wouldn't be able to do that. But as also outlined by, for instance, John Stintz and Peter Beek, there are definitely higher order cognitive processes that can influence balance control. And this is especially apparent when you, for instance, distract people, so take away attention and make it more difficult for people to actually use these higher order cognitive processes to control their balance. Even in healthy young adults, we see that when you, for instance, give people a dual task, it will affect their control of balance and gait. So for instance, these are results from a study by my collaborator, Toby Elmers, And in this particular study, he asked people to walk down a winding path, and during navigating this route, to also make some accurate steps towards certain targets along the way. And when people did this by themselves, they were quite accurate and quite fast in completing the task. But when they also had to do an extra additional cognitive task, subtractions, then basically what start to emerge are these so-called dual task costs that you see here. So basically, these reflect the difference in performance on each of these tasks when compared with performing these tasks in isolation. So when people were required to do these tasks at the same time, they got less accurate at the cognitive task, they moved more slowly, and this did come also at the cost of their stepping accuracy. So just to show that definitely we can influence our balance control by either paying attention to it or not paying attention to it. And what we know is that in aging and clinical populations, the degree to which we rely on this higher order cognitive control and attentional resources to control our balance, our reliance on this increases quite a bit, and especially in clinical populations, such as people with stroke or Parkinson's, or people with excessive fear of falling. So what we see is, for instance, increased dual task interference. So those dual task costs, they increase when we age. And stroke and Parkinson's disease patients, they could even have quite significant, lead to significant impairments in balance and gait. We also see additional recruitment of prefrontal areas during the control of balance and gait, so neural activity in those areas related to higher order control that increases. And we see that people also just self-report paying much more attention to their movements when you use validated questionnaires for that. And anxiety and fear seem to play a key role in this. So we know that when you are anxious or fearful, you often start focusing on your movements. You know, you might notice from like when you were playing sports or when you were in a competitive game and there's an important point, often you become much more self-aware, at least. And in lab studies, we also see this happening a lot. So for instance, when you make people anxious, for instance, by presenting an immediate threat, so you put people at height, or you tell them that they might be perturbed in the coming balance attempts, then what you see is typically people becoming fearful and also at the same time starting to focus on their movements more. On the longer term, and this is what happens in clinical populations and aging, you can also develop a more like elevated trait anxiety. So where you become more fearful, potentially because you have been exposed to certain situations, experienced situations in which your balance was threatened and you were less able to deal with it, and you develop some sort of generalized anxiety about falling. Could be accurate or could be inaccurate. I'll come to that in a second. So typically, of course, this can be really adaptive, right? When you become fearful, you would typically show protective behavioral changes that should improve your stability. So you walk a bit more slowly with wider steps, shorter steps, which should help you also improve, for instance, anterior stability and dealing with slips, etc. And Nick Kluft also showed this quite elegantly, that when people are presented with a postural threat, they might select more cautious stepping strategies that allow them to, again, increase their stability a bit, for instance, when stepping down in that case. And with static balance, we also see changes in how center of mass is controlled. In essence, changes that help people to ensure that their center of mass remains within their margins of stability more effectively. For instance, reduced sway, increased frequency of sway, and increased co-contraction. So that's all really adaptive. And we also know that anxiety can really help scale these responses to the threat. So when you're presented with, for instance, different heights, when you're standing at height, and you're presented with increasingly high heights, and you need to deal with that and control your balance, what you would see, and this is a famous example from Alan Atkin and collaborators, is that the protective postural control responses are scaled to the level of the threat. So the higher you get, the more you see the more your behavior is exaggerated. So what you can see here is the sway in the anterior posterior direction, so frontward, backward. And what you see is that people, when they are in a low threatening condition, they have quite a bit of sway, and then it progressively reduces when people are at higher heights. And then also there's frequency of sway, which helps people to maintain their sway, to more tightly control their sway, so to say, to put it simply. That progressively increases. So it is scaled to the postural threat. And we also know that associated attentional changes that occur during these different during these exposures to anxiety, to threatening conditions, they may actually, for instance, directly influence these behaviors, such as leading to a bit more backward lean that has been associated with like the increased control of movement during these situations. And that, of course, is protective when you're presented with a threat right in front of you. And other studies have also shown that when we're anxious, we can really dynamically adapt our sway patterns also to different directions of the threat. So when the threat is suddenly from the sides, from mediolateral directions, then our sway would, of course, actually mostly be reduced mediolaterally, but will be much more free to vary in an anterior posterior direction. So these are all really adaptive changes, and we know that conscious processing can also help us achieve these changes. But sometimes it's maladaptive, and that's what I'm getting to today. And what we think is that when anxiety is unwarranted, so it's excessive, or when it results in excessive attention to movement, which is usually tightly coupled, the resultant changes in balance, those otherwise protective changes, will now be improperly scaled and therefore maladaptive. So, for instance, overly cautious for those individuals with excessively cautious gait. Or, and that is what happens in unexplained dizziness, people might now think they're unstable, whereas they in actual fact aren't that unstable at all. So they might have distorted perceptions of their stability due to this increased anxiety coupled to this increased conscious processing of their balance. So this is what we think is a potential shared mechanism that basically underpins these two groups, the behavioral things we observe, the changes we observe in these groups. And what we think is that when people are anxious, and especially when this anxiety is unwarranted, not scaled to the threat anymore, that this results in excessive conscious processing of their balance, and that this leads to distorted perceptions of stability, where people think they're more unstable than they actually are. There is some evidence that this happens when people are anxious. So Cleworth and Carpenter actually showed that when people are anxious, they perceive themselves to be swaying more than they actually are. But no one to date has convincingly showed that this is uniquely underpinned by excessive conscious processing, because usually this changes at the same time as anxiety changes. So it's difficult to isolate any effects of anxiety from those of like attention to movement. So we created a basic model of how we think this will actually work in practice. So what we think is anxiety, and this is really simplified, so I can make it a lot more complex, but I'm not going to do that now because there's no point for this talk. But I think this is the meat of it. So when people are fearful, they become focus on their movement, but because fear in first instance might not have been appropriately scaled, this actually results in excessive attention to movement, excessive conscious monitoring of balance. So what we think is that people, due to this, become increasingly sensitive to, or increasingly susceptible to actually starting to consciously perceive changes in their balance. So they notice them earlier, they become aware of them earlier, even with like smaller changes than what normally would happen. And also they now have a negative bias toward evaluating these changes. So they interpret them as being more threatening than they actually are. So there's these two processes that maybe take place. And this is what drives those inaccurate perceptions of instability, which is a key symptom of dizziness, of course. We also think that then leads to those inappropriately defensive responses, and that by itself, when you perceive yourself to be more unstable than you actually are, to then lead to more exaggerated feelings of fear. So it might actually reinforce this fear response. And within, for instance, a bout of dizziness, this is what actually might make your dizziness worse. So in the moment, but over a period of time, so longer time scales, this might also lead to reinforce your trait levels of anxiety and associated traits, sort of hypervigilance, that we think is starting to occur, where people are sort of continuously in a state of alarm, so to say, and become really sensitive to otherwise innocuous changes in their balance. So this could, in the long term, lead to more sort of chronic, unexplained dizziness complaints, we think. Okay, so what I'm going to present is two studies. One is sort of more proof of concept study. So as I said, there are some indications that when people are anxious, they have acutely less accurate perceptions of their stability potentially. But what we try to investigate is if it is conscious processing that really is the key driver of this. And the second study is a study where we actually wanted to focus more on the clinical utility of our model and see if we can develop a self-report outcome measure of vigilance and actually accurately and reliably measure this in people with and without dizziness, and also use it to, for instance, dissociate or distinguish between those people that are dizzy versus that are not dizzy, that don't have this unexplained dizziness in daily life. So starting with the first study, it was, and most of this work, by the way, I must say, has been very much also heavily inspired, heavily led by Toby Elmers. And so we closely collaborate on this topic. And this study was published almost a year ago. So what we did is we recruited older adults. We just finished this before the pandemic, so we were quite lucky. We recruited older adults who were around 74 years of age, but there was quite a spread. So the youngest was 60 and the oldest was almost 90, I think 87. This sample constituted mostly of women. And it's important to realize that the sample we recruited didn't have any neurological impairments, no vestibular diagnosis, so they couldn't have like organic dizziness, so to say. And because we really wanted to do a proof of principle study to see if we can actually isolate these behaviors, we also focused on people who didn't have any recent bouts of dizziness. So I'll get to the clinical population in the second study. If you look at the population, they had some balance impairments, but on average, they were relatively highly functioning, but there was some variability. Same applies to the Montreal cognitive assessment scores. People couldn't have major cognitive impairment, but there were people who definitely had some mild cognitive impairments. And people had some concerns about their falling, as evidenced by the Falls Efficacy Scale international scores. So what did we do? Well, we had three main conditions in which we tested people's static balance. So we had a low threat condition where people were just standing at ground level on a force plate at the edge and were asked to stand still and look straight ahead at a fixation point in front of them. And we measured their actual balance, so their sway, basically in the anterior posterior direction, their perceived stability, and also their fear and conscious processing. Then we basically repeated this, although these were not necessarily done in this order, but we also did this in a high threat condition where people were standing at the edge of an elevated platform now. And again, they have received the same instructions, namely to stand still, and we measured the same outcomes. But of course, what we expected is that people would be more fearful and more consciously processing their balance and perceiving themselves to be less stable at this point. But it doesn't allow us to isolate the effects of conscious processing here. So we also added the third condition where we basically tried to minimize conscious processing during this high threat condition using a simple yet really distracting task of basically cycling through the names of all the months of the year throughout the trial. So what we did is we basically always started with the high threat conditions because we know that initial exposure to a threat usually leads to the best, like solid, most robust fear response. And then we counterbalance though the order in which we did these two high threat conditions. And then after a washout period, we did the baseline low threat condition at the end. Okay, so what did we find? In terms of fear, which you can see here, fear falling 0 to 100%, with 100% being scared to death, basically. But what you can see that there was a robust fear response when people were standing at height versus at ground level. So that's good. They also showed increases in conscious processing. We measured this with a state version of the reinvestment scale. So that's a self-report measure of how much people are focusing on their movements. Again, there was a significant increase. We measured actual stability using the force plate, and that remained similar between baseline and high threat. And we measured perceived stability, and that dropped quite a bit. That dropped by 20-ish% from baseline to high threat. So you already see starting to emerge some sort of disparity here between what happened to their sway and their perceived sway in this baseline versus high threat comparison. If you then look at what happens when people were distracted, so when they were fearful but not able to process their movements as much. We saw that fear basically remained similar. So that's good, because that allows us potentially to isolate the conscious processing effects and what happens when you take that away, especially because conscious processing, as you can see here, significantly dropped during the distraction condition. So people were as fearful, but they were just not able to focus on their movements as much as during the other high threat condition. If you look at actual stability then, that stayed exactly the same statistically speaking, but also even almost like numerically speaking. And perceived stability then, and what we would expect is that it would normalize. That was partially confirmed. So if you look here, perceived stability again, where it dropped first 20% here, it now bounced back by around 10% when people were distracted. So this is early evidence that at least there is something happening here where when you withdraw attention to movement, when you reduce conscious processing, when people are fearful, their perceptions of instability normalize. They become better aligned with what you see happening in terms of like actual stability. That said, while this is some initial behavioral evidence that anxiety-induced conscious processing can drive distorted perceptions of instability, it must be admitted, though, that there was not a full like normalization here of perceived instability. People were still perceiving themselves to be 10% less stable than when at ground level, even though when you look at their conscious processing, that was basically returned to baseline levels. So there must be something else that also drives this, and that makes total sense, I would say. And likely that is that elevated fear that was still present during this condition. So for instance, we know that when people are fearful, there might be some sensory changes in terms of like sensory gain and increases therein, such as enhanced muscle spindle sensitivity, enhancement of vestibular feedback. That could lead people to still perceive themselves to be swaying a bit more than they are. So to lead to these altered perceptions of sway. So it's definitely not the case that it is the only factor underpinning this, but I think we show here that at least there is some causal relationship there. And what we actually did also in an additional analysis in this paper is we had some other data of people who did the similar task, similar group of older adults. We did a baseline versus high threat comparison, but just didn't do the distraction task in that study. So when we collapsed their data with our sample, we basically looked at what happened to perceived stability, whether conscious processing in predicted perceived stability when at height. And the regression analysis showed that, yes, conscious processing was actually the main predictor, even when correcting for actual sway and also for fear results. So that suggests, again, that it has some causal relationship in all likelihood. But definitely it's not definitive proof, but it's a good start. It's a good proof of principle, we would say. One thing you might say is then, okay, but if this happens, and even in people who don't have dizziness, why don't we all get dizzy all the time then as soon as we get anxious? Because that's what you would expect. If it's such a robust effect, why wouldn't it happen? And that, in all likelihood, has to do with adaptation and the fact that when we are anxious and when we are, for instance, exposed to such an environment where you have to stand at height, there are some studies that show that you really rapidly adapt, so that both your fear response, your conscious processing, also associated postural behaviors rapidly attenuate, and that makes it, and that basically your perceptions of stability will likely also normalize quite rapidly and become more aligned with the actual threat you're presented with. And from a safety point of view, it also makes sense to initially overestimate your perceived instability, because then you make some adaptations so that at the very least you will not fall. It might not be as efficient as you like, but they will definitely help you maintain your stability. But then you adapt very rapidly as soon as you are better able to fully gauge like the threat at hand and perceive it accurately. What happens in people with dizziness, we think, is that, as I say, that some experiences they may have during daily life, where they, for instance, have particularly like traumatic bouts of dizziness, that maybe lead to a fall, that may lead to more elevated levels of trait anxiety that are reinforced over time, and also more longer-term elevated vigilance of balance scores. And what then could happen is that basically they fail to adapt. They fail to really rapidly attenuate their responses and are more in this continuous sort of state of mild alarm, so to say. So that is something that we began to test with study 2 to see if there was any truth to that. So what we did here is we developed a questionnaire, a self-report outcome measure, which is typically typically used in clinical practice, these types of outcomes, to see if we can basically measure this behavior. And it should be quite easy to measure it by self-report, because it is one of those, what we know with fear and with conscious processing, that by default, you can report on it. So what we did is we developed a tool to measure this. And what we were mostly interested in is, of course, if it's a valid tool, or is there a reliable tool, if it is some basic aspects of validity, structural validity, etc. But also if there's some predictive validity there. So if higher scores on this questionnaire, which we call the Balance-vigilance questionnaire, whether those are associated with a greater probability of experiencing dizziness in daily life. So that is what I will focus on, but I will present a little, just tiny bit on the more dry stuff of the validation so that you have a bit more context. So what we started out with was adapting an existing measure, so the pain, vigilance, and awareness scale. So similar measures of similar processes might actually also take, as I'm describing here, might also be relevant to pain. I'm not going to go into that because that's a quagmire of a field, but this scale has been used extensively, and it was a good starting point for us to adapt for balance, vigilance related to balance specifically. And of course, one thing you could do is just take the questionnaire, remove the word pain everywhere, and then insert balance, Control H. But that would lead to quite ridiculous questions, so wouldn't recommend that. So what we did is we basically got together with a group of clinicians with expertise in dizziness, with some researchers, and also some older adults and patients with certain balance disorders. And we, Toby, Elmar, and me, adapted the initial version, created the initial version based on the pain, vigilance, awareness scale, sent it out for review, and then through an iterative process, we honed in on the final questionnaire. And this consisted of 11 items that were scored on a 5-point Likert scale. So people for different items related to how much they were monitoring and attentive to minor changes in their balance. People would indicate if they never do this, score of 1, to always, score of 5. I'll show you the definitive scale on the second slide, because this was the starting point. We didn't end with this scale. This is what we initially wanted to validate, but during validation, you might lose items, and that's what happened. So what we did is we recruited a sample of older adults with and without dizziness, people with a particular dizziness disorder, which is called persistent postural-perceptual dizziness, PPPD. And this disorder is actually quite similar to unexplained dizziness in that people, although it's an official diagnosis, people don't necessarily have a clear vestibular underpinning deficit, but still experience a lot of dizziness. So we think the mechanisms are quite similar here. And people with actual organic vestibular deficits, so vestibular diagnosis. We included all these people, but this recruitment was all done online through different PPPD support groups, other forums, etc. Because this was in the middle of our very elongated long lockdown period, very prolonged lockdown period here in the UK. So this was the only thing we could do. But what we did is we it did allow large numbers, so that was good. And what we did is we recorded a lot of background information relevant to dizziness, so some risk factors, and we let people complete the Balance-vigilance questionnaire and some other commonly used assessments that may predict people's dizziness status. People also completed this 2 weeks later to determine retest reliability. And we included a follow-up period of 6 months, because what we wanted to do, if you have such a scale, you want it to be able to, for instance, to use it to predict changes in dizziness based on balance vigilance. I have to be a little bit, maybe disappoint people, but I don't have that follow-up data yet, because we're literally in the process of analyzing all the data, but we did finish the validation stage. And I'm now going to present some results on the older adults, which were quite promising, I would say. So we ended up with this questionnaire. These are the 6 questions. So you can see that these questions, we dropped 5 basically, because a lot of them, or 3 of them, weren't really reliable on an individual level. And 2 of them also were dropped out during the factor analysis stage. So they didn't really match with the other items, so to say. They didn't really measure the same construct. And you can see that all these items really relate to a combination of anxiety and conscious monitoring of your current state. So it includes some things related to worry, becoming alarmed by sudden changes in your steadiness or balance. And basically the scores add up to a 30 with a minimum score of 6. If you say, no, nothing applies to me, you score 6, and 30 is completely, utterly vigilant behavior. Okay, so I already explained that we did factor analysis. That's done to just check the structural validity of the scale. That was all good. Reliability, I'm not going to bore you too much with the details on the numbers, but that was good. One thing that was important to note is that the minimal detectable change is 0.9. That will be important on the next slide. So that is to say that when two groups score more than 1 point apart, that exceeds measurement error. So it's probably a reliable change or difference. So regarding validity, and that's the most interesting thing, what we wanted to see is whether the scale correlated with some other measures that tap into anxiety, like the hospital anxiety depression scale. And it did that, but just with a small correlation coefficient of 0.34. That is good because that suggests that it measures something related to anxiety, not necessarily the same thing as other measures, which we expected. But this is the most important thing. So can we use this scale to predict dizziness in people, in older adults in daily life? So when you look at the group of older adults, we had a third of people who had actual dizziness. This was based on a self-report questionnaire, of course, so a self-report question, but that's typically done actually. For instance, Menon et al. Also used the same approach. And a third of participants actually quite closely matches with what we know about dizziness in older adults in terms of its prevalence. So that's quite reassuring. Similar to our other study, most people were female. People who were dizzy had greater fall incidence in the past year. Used a similar number of medications. That is usually not the case, but it could happen. Anxiety was higher, as you would expect, as measured with the hospital anxiety depression scale. Scale. And depression diagnosis was also higher. It's also a known risk factor for dizziness. And of course, as you would expect, dizziness severity, as measured with the vertigo symptom scale, was also higher. That should be the case, of course. If you now look at the balance-vigilance scores, these are the results for the two groups. So what you can see is the balance score, vigilance score on the y-axis, ranging 6 to 30. And what you can see that scores on median scores were quite 3 points higher, 4 points higher almost than for the dizzy compared to the non-dizzy group. So people were more vigilant related to balance. And it was highly significant. But looking at this data, you can already also see that a lot of people who are highly vigilant aren't dizzy. So probably that is partly related to all those other confounding factors that I showed you on the previous slide. So to figure out to what degree that caused these differences, we also did a logistic regression to basically predict dizziness status and to then correct for other confounding factors. And you can see the results here. I'm just going to focus on the highlighted bits. So what we found is that there was an increased odds. So people were more likely to be classified or to self-report dizziness when they had higher scores on the balance-vigilance scores. So there was a significant association there, but also when they had higher scores on the anxiety subscale of the HUDs. Again, significant association and not too dissimilar odds ratios. Age, number of medications, depression, gender, they all didn't necessarily associate with dizziness status, but it's good to see that the balance-vigilance score associated with it, even when you correct for these confounding variables. So that, in a nutshell, are the early results. What we now need to actually find out is also whether it predicts changes in dizziness, longitudinally speaking, because that would be more evidence for the causal role of dizziness, of balance-vigilance in triggering and sustaining dizziness. That said, I think this is a promising step because it provides us a reliable and valid tool to use to do that research. The fact that it associates dizziness status, even when you control for known confounds, is quite encouraging. But of course, we cannot say anything about causality yet. It's an association. If you are dizzy, you're also likely to become more vigilant, as also highlighted in the model I showed you at the beginning. So what comes first? That is now a crucial question to further look into. But I guess the proof of principle study that I presented at the beginning does suggest that vigilance by itself can at least reinforce this behavior and make it worse. So I think that's a promising start. So what we're now going to do is focus on this and looking whether this score here can actually help us see how people's dizziness develops over time over the 6 months after we first let them fill out these questions. So that's a key thing to further look into, and we're also going to measure, ask people to report like how many times they've fallen, to see if there's also some other aspects there that can be interesting to take into account. So you can imagine that people who did fall in between might also have much elevated anxiety and dizziness right after. So that could be a factor to further look into. So in overall, I think what we presented here is just a start. It's definitely not definitive proof for anything, but it is a potential mechanism that that can explain potentially how anxiety and associated vigilance could help trigger or sustain dizziness symptoms. What would be very interesting to further look into is like the underlying mechanisms. So has it to do also with some changes in sensory gain, or is it more really that higher order cognitive behavior of appraising the sensory information you get and being more negatively biased there, so that you interpret it as being more threatening than it is? Is the combination? That's stuff that Toby is also really focusing on now in his work at Imperial. And from a clinical point of view, that's more my thing at the moment. I'm gonna look at further developing the skill and also looking at these longitudinal changes. But I think eventually this can potentially be really useful in clinical practice and maybe help therapists. It's a long way down the road, but help therapists to make more informed decisions regarding treatment, and that using treatments that could normalize vigilance, for instance, cognitive behavioral therapy or mindfulness-based therapies that have been proven useful in other similar areas and patient populations. They might actually be especially useful to use in this regard. Okay, that was all. I hope it was interesting, but if not, let me know. Any feedback is welcome.
Well, thank you, Elmar, and I think it was interesting. So,
Okay.
and I'm also sure that some of my colleagues have questions for you. So, if you have questions,
sure.
of course, then please grab your chance and ask a question to Elmar. Maybe you can stop sharing the screen so that we can.
Oh yeah, sorry. Yeah.
Always
there we go.
better, I guess. Anybody?
I have a question, if I may. Thanks, Elmar, for this very nice presentation. I was wondering, in your first study, you were talking about anxiety and fear and the high threat condition.
Yeah.
But these tasks were all in like static tasks, right? Standing still as much as possible.
Yeah.
Display. How do you think? Do you know of some speculations maybe of how that vigilance would work? Would that be less or even worse when you have dynamic tasks under threat? So if you receive more feedback of movement, correcting whether or not your balance is getting worse or better, would that induce more vigilance or less?
So maybe it's good to make a distinction also between state and trait vigilance. So what we tried to evoke in that study was state vigilance, which definitely, I think, so that could be increased or decreased when you have more information available, if that makes sense. So I think when you have like some of these patients, if you talk to them, especially people with PPPD, which I didn't present any results on, but the results were fairly similar. They are so preoccupied with this that with gait, they would I'm not sure if they can get more vigilant. So if you look at clinical patient populations, I'm not sure if they can get more vigilant. What I would say with like the sample we used in that particular study 1, which weren't patients, which were like healthy older adults, it might actually help you adapt more easily to maybe initially disparate perceptions of your stability. So if you have more feedback, it might actually help you attenuate such vigilance more easily, because you get more feedback that can help you calibrate your perceptions. But I think that's also where that trait vigilance comes into play. So if your bias is really negative, then that adaptation might be slower or even non-existent. So your higher order cognitive sort of bias might actually overrule that, if that makes sense. You're just not able to learn from your sensory feedback as well, because you're so colored in your interpretations through your strong trait vigilance. That would be this is speculation. I don't have data, so it's just
an idea. Yeah, I can fully understand what you're saying. It would be nice to see if you can disentangle that. Yeah, thanks.
Jaap, you had a question.
Thanks, Elmar. Very nice presentation. I do have a question about, you suggest that maybe increased sensory gains could underlie some of the changes that you see. Now, there's some work from Mark Carpenter's group on this, where they do show that there are stronger reflex responses, for example, when standing at an elevation than when standing at a level surface, which suggests an increased sensory gain, but at the same time, they do not show increased cortical evoked responses. Yeah. So how do you reconcile that with this hypothesis that you...
Yeah, that's very true. So it might actually, that's good. I actually reread that study yesterday. So I thought this question might pop up. So that is difficult to reconcile, actually. So we are planning to do a similar study, or well, actually, I say we, but Toby is planning to look more closely at this. So if you also look at our data, what you see is that people were showing a reduction in conscious processing, but they still scored, I think, 7 out of 12 points. So it was similar to baseline, but it was still quite high. So people did have access to their, or at least they reported to have access to sensory feedback related to balance, and reported to consciously monitor it. So it could still also be that, because we didn't fully sort of block it out, that there was residual opportunities for them to still appraise their feedback, and even though that, like, so suppose that sensory gain isn't changed, or at least that it doesn't affect, isn't changed in terms of how much sensory information is processed cortically. So at that level, it isn't changed. It could be that the information that they do get is still open to conscious appraisal, because it still did have that residual conscious processing of movement that they reported. So that through that, it might still have led to sort of greater disruptions of their perceived stability. But I get what you're saying. I actually don't know. I mean, this is what current thought pattern, but then when I read that study, I thought, this is actually difficult to reconcile. So if you have any suggestions yourself, this is also really early days for us in this topic.
I don't really know. I don't have really a suggestion, but I was thinking along the lines that maybe sensory noise could also be affected. Like if you have a constant input noise into the sensory system, let's say,
yes,
spindles, and you increase the gains, obviously the variance of the output will also be higher. And that might increase, let's say, the uncertainty about the interpretation of that information.
Oh, that's a variant. Yeah, that does sound really plausible. Yeah, that could very well happen, because that could then lead to also those vague sensations of, as you say, stability.
However, then I was thinking, okay, but then I would expect to see an increase in postural sway as well, and I didn't. That's then of what they observed.
I think what is difficult and a limitation is maybe people had that at the start of the trial, so we just average it over the entire trial here, right? So it could be that, and of course, there's a different sort of temporal dynamic going on where you report this after the fact, but the sway is affected during the trial. So it could be that your initial perception of increased instability led, or that increased noise led to some increased sway, and then appropriate action was taken to then get sway down again. during the latter parts of the trial, but after the trial, you're asked to report on your perceived stability. And that initial experience of being a bit more unstable due to this noise might actually have led you to score a bit higher in terms of perceived instability. Does that make sense? It's maybe a measure to sort of temporally track both during a trial. And a carpenter tried to do that with like a joystick where people track their sway, and a Cleveland carpenter, but that wasn't an ideal method as far as I could tell, as in people were really, really bad at that, I think. So it's very hard to, I guess, track this on the go, but that would be ideal because then you can directly see more like the cross correlations, I guess. That's a clear downside with these self-report measures. You measure some things after the fact or before, but during is quite hard. Yeah. Thanks for the question and suggestion. That's really interesting.
All right. Any other questions? Did I hear someone? No.
I think you hear my cat. It's freaked out.
No. Elmar, in terms of helping these people, do I understand you correctly that one avenue would be to actually make the perception of instability or stability more accurate? And if so, do you have any ideas how you would go about with that?
So what they do with some of these vestibular patients, at least, is a sort of graded exposure, as in they expose people to different manipulations, and that seems to help normalize some of the exaggerated responses that they may have. I think it will always have to be. So what you see in breathing, which I weirdly enough also have some sort of involvement in through some physio colleagues here, is that some people with dysfunctional breathing, so hyperventilation syndrome type of things, they seem to have similar things going on where they are excessively monitoring minute changes in their breathing, and that can by itself sometimes be like a trigger for them to get into a hyperventilation sort of episode. And in that field, they have much more clinical work in this population in terms of dysfunctional breathing that I at least have recently been in touch with. And what they do is a lot of exposure where people do breathing exercises. So they learn, it's actually really conscious, but you would say might be wrong. But what they learn to do is use their conscious control and monitoring in a way that is adaptive. So they learn to experience what's going on, which is a bit like mindfulness without trying to intervene. So taking a neutral stance to what they're feeling, and then hopefully through exposure to like changes in their breathing and then realizing that actually nothing is happening, it could both reduce anxiety, but also the associated sort of thought processes that may take place. So their interpretation of the changes they experience in terms of sensory feedback on breathing, etc. Does that make sense?
Yes, I think so.
Okay.
I was actually thinking that maybe that you could use virtual reality and then play around with the link between actual stability and perceived stability.
Yeah, that's really cool. Yeah, Toby works a lot with Adolpha Bronstein in the Imperial, and they also look at visual dependence, like with the moving room illusion, where you are. They had a literal moving room back then, so they created a room and they sort of perturbed it, and then that by evaluating the postural responses to this, they could see like how much visual dependence people had, etc. And you could actually play around with that to check to what degree people are exaggeratedly responding to this, but also maybe by playing around with this and more like subliminal changes, you can actually try and help people adapt again. I think it's all about adaptation that is lacking, but that is something I've been discussing with Toby like just like yesterday as well. So we're very much like trying to figure out what would be a good step, and he's looking really into this part as well. It's a pity he couldn't join, but he had to work on that basically. So yeah, so I think in the coming, Toby is really looking more at like these visual dependency and some of these more underlying changes in potentially sensory gain and other more mechanistic how do you say it, factors, and how they, these may play a role here. So I think there will be some exciting work from that lab coming out pretty soon. And if you're more interested in the clinical stuff, which I'm at the moment but I'm still dabbling in that other stuff as well, the mechanistic stuff. But then that is more my focus at the moment.
All right, I think there's time for one more question, and then, so if anybody wants to ask a final question, then please do. If not, then thank you all. And again, apologies for the chaotic start, also to the students who came in later, I see, which is good that they still came in. And then we see you all next time, I guess. And thanks, Elmar, for interesting talk.
Cheers. Thank you.